So, welcome. Thank you for attending. So I just wanted to talk briefly about charting. We all do it, or should be, but I think it's time that we have a discussion about where our charting is going. So I'd like to talk about just some elements of a good eMERGE chart, talk about some types of chart systems, quick review of EMR productivity, a little discussion on what we should do with respect to medical student charting, and then let you know what's coming. So there's the College of Physicians and Surgeons of New Brunswick has a peer assessment committee, and the expectation is that somewhere within the next decade, we're all going to have our charts formally reviewed. So an ER chart basically is what we write on every day. It's meant to be a focused history and physical exam. And probably the best way to describe it is it's somewhere between a quick SOAP note and an internal medicine 5-page full history and physical. And what you actually are charting really is dependent upon the level of illness of the patient and the amount of medical input that you have to are involved with. According to the College of Physicians and Surgeons of Ontario, the purposes of a chart are the 4 outlined items there. Basically, it's to allow you to recall items and to monitor the progress of the treatment. And I think that's something that we don't often think of, that the chart is meant to be our way of monitoring our progress of our patient. So that means that we should be updating it regularly as during the patient visit. It's something our colleagues can use when called on to treat the patient. We don't so much have locums in eMERGE, but it's certainly, we've all gone to previous charts. Sometimes it's your only information on a patient that might be altered. And when you go to that and you find that it's illegible or there's nothing really written there, it's not all that helpful. It's useful for a medical legal reference, such as for someone needing information for a workplace injury or an accident injury. And it also helps you if you've got to present evidence in court. And also, as we've all found out during our recent rash of catching up on our physician complaints, it's also helpful when there's complaints. So I'd like you to read these and just kind of think to yourself what your own answers would be. I've done this myself, and I certainly have noted that I have some errors and omissions in my charting, and hopefully that I will find this talk an opportunity to kind of review that and improve. But sometimes we don't find, or we don't realize that there's things missing in our charting until there's an issue. I find that charting is a lot like a sine wave. When you start out, you're writing pages and pages and pages, and then as you continue on, you start to write less and less and less until you have an issue where there's a complaint or a bad outcome. And then all of a sudden you're back up to writing pages and pages and pages again until that interaction or that issue fades, and then you're back to brief notes. So why don't we do a good job of charting? Well, we're going to eMERGE. It's busy. There's lots going on. So we feel that we don't have time, or sometimes we really don't have time. You're working in RAS or in Sussex by yourself and it's busy. You might have 4 or 5 charts laying on the counter, that patients that you've seen and discharged that haven't finished the chart. Some people, it's just a bad habit. Not really a charter. Sometimes the layout of the chart makes it difficult for us to put the information in that we want. Certainly the method of charting can make it difficult if you're doing dictation or typing or an EMR and there's no access to the computer at the moment. And not so much here, I think, but or more so here rather than in the US, but a perceived lack of value. So when you're looking at working in a fee-for-service system, you're able to bill based on what's written in the chart. So if your income is directly tied to what you've written on the chart, you tend to do a pretty good job of making sure that everything is documented. So in general, according to the New Brunswick College, the Peer Assessment Committee, which we'll talk about more later, the patient record should stand on its own as a chronicle of the patient history and care, provides the reader with an understanding of how and why certain decisions were made. The overall content and quality should provide a clear and accurate guide which will enable an incoming physician to assume the care of the patient without hesitation and without difficulty. And I would suggest that for a lot of our patients, and we'll get into this in a bit, but again, it depends on the complexity of the patient. If you show up with a medication, prescription request, you're likely not going to need a full 5-page history and physical. We're lucky because a lot of the information that's required on a good chart is already collected for us. So the date, the PPRN, the name, the age, the gender, method of arrival, the substitute decision maker, all these things are already on our chart. Be careful with your electronic complaint though. They're a drop-down menu and it could very well be wrong. The triage nurse may click the wrong one. And the other thing to note is, and CMPA will back me up on this, you ignore nursing notes at your peril. So if the nurses have commented that the patient is, non-responsive or the baby is floppy and you don't address this in your chart somewhere, then you've got an immediate conflict on the one record of the patient's visit, which is something that prosecuting malpractice lawyers look for. And sometimes we're lucky and we have the allergies and medications on the chart, or we have a printed out list of the medications. And again, certainly I think that happens in our department most times for the sicker patients. The CMPA Good Practices Guide suggests that the clinical notes don't need to be exhaustive, but they do have to give you an adequate picture of the clinical situation. And I'll highlight a couple of these items just because I think they're things that are becoming more and more relevant to our practice here in St. John, but the source of the information. So we're getting a lot of people now who we have communications issues with. They are new immigrants who don't speak English, and I certainly don't speak Farsi or Arabic. So, where is that information coming from? Is it translated by their son or daughter? Is it coming from the language line? These are important issues because if there are negative outcomes on the chart, you want to be sure that you've included all of the difficulties that were there in terms of getting the history. As far as the history and physicals, again, I think we all do a pretty good job of identifying the positive and the important negative findings. As far as the working differential and final diagnosis, a lot of times there is no working or differential diagnosis. There is just a final diagnosis. As far as the plan of action, I think we're lucky because for the most part, although we do write some of these things in the physician orders, most of these things go in the computer at one point or another. And I think it's important to recognize that our charts are a combination of both paper and electronic record. And I think it's really important to remember to put your consults in a timely manner, because that time that's on the consult in the computer is the time that is looked at in any sort of a dispute. As far as information given to a patient, particularly now in COVID times, I think it's important to document on the chart if you've called home and spoken with a loved one and given them an update of what's happened with their patient, particularly because of the inability for visitors in the emerge. I think we all do a pretty good job on the second last point, and that is that if there is a refusal of care or if there's a disagreement with the patient, I think it's important to document that clearly at the time, because these are the charts that are most likely to come back as a complaint or legal action. And last but not least, the signature of the writer and the physician. So sometimes when I look at the chart, I have no idea who saw the patient because there are some signatures that I don't recognize. CMPA suggests that if your signature is not legible, and I don't mean that in a negative way. Some people have a unique signature and we've come to recognize them, but if you don't work in our department, it would be helpful if you had printed your last name underneath, and certainly if you have trainees, for them to write their trainee level on the chart. A lot of times you pick up a chart and there are 4 signatures at the bottom of the chart and you have no idea who's who or what's who's what age or what level they're at. So, and then of course discharge instructions. So your one defense, in terms of a patient that has a declining condition after they're discharged, is your discharge instructions. And again, some of these things, according to the CMPA, have already been done. We've already documented clearly in the chart who was consulted and what investigations were done and what were taken, and that's all in the computer system. But certainly you'd better document your follow-up plans and clearly include reasons to return to the emergency department. And then handover. I think, I am notoriously poor at documenting handover on my chart. I'm not sure what other people are like, but I certainly don't see a whole lot of us doing a great job of documenting things. Again, our charts just aren't really big enough to write all of this. But I think a lot of us will write this on a separate sheet of paper, but if it's not part of the medical record and it goes missing, then you no longer have that record. So, but you should definitely document clearly who should be taking over responsibility and when. So, at the very least, I think a minimum would be handed over to Dr. Page at 1600. And, if you wanted to get a little more fancy, then you certainly could write your differential at the time or something on there on concerns. But I think at the very least, you should document that it was handed over. Should always document any procedures or inventions that you've done. Again, we're lucky because if you put the orders in the computer, the times are already there. Always try and document your first interaction with patients. So in that first interaction may be when you've signed the ECG. So that's helpful that you put the time on that. Clearly, someone looked at this patient's ECG 2 hours before they came into the emergency department and it looked fine then. So, their complaint about all of the time they spent in the waiting room being unseen and left to decline, we did have some interaction, although it's not a formal interaction, but at least it gives you some defense. Vital signs, check your vital signs. Again, make sure they're there for starters. Make sure that they're updated. Typically, you should note some sort of abnormal vital signs on the chart, circle them, initial them. When you go to reassess, you should document those times. And again, documenting communications on the patient's behalf. A lot of these things are in the chart. For example, the order for a CT or the consultant referral. But, things like calling the nursing home or, if the CBC is taking a long time to come back, you should probably document the time that you called the lab to look for that particular item. Special signs should be on there. So again, that's your positive or negative. So as Roth Singhs and Optrator often are positive in appendicitis, but, we've all been taught that we're supposed to look for those things. So if they're not on there, then it just looks a little bit sloppy. Explain abnormal vitals if you can. So if somebody's hypertensive and they forgot to take their blood pressure med, just note that he didn't take his blood pressure medication today. When you're talking with consultants, I think this probably would be better off just in your consult. But if you're talking to the cardiologist about a guy with chest pain that's got a troponin of 900, somewhere in your your referral or your chart, it should be noted that you've made them aware of that. And then you've got what I like to call historic alternans. So when the patient comes in with one complaint and when they get there it's a different complaint, try and explain that. Sometimes it's just we have a patient now who's coming in with all kinds of weird and wonderful complaints as a method to try and get himself into the emerge quickly. So clearly identify why the story and the presentation are not the same. And then lastly, if you've got a learner, make sure that you've documented your interaction with the patient. So, a simple laceration on an adult, when you've got a third-year emerge resident, you're probably not going to have a whole lot of interaction with that patient. Whereas, if you've got a third-year medical student and the patient's short of breath, you're probably going to repeat a significant portion of the history and physical, and should clearly document that you've done so. Again, both for your own memory and for medical legal purposes, so that you can show your level of involvement. Bottom line is you're responsible regardless, but it's sometimes helpful for your own memory to remember that, oh yes, I did go and examine this patient and I did do my own history and physical, and these were my thoughts. Avoid using your own acronyms. And you can read those. I mean, I think one of my favorites is the sock mob, because we see that seemingly every Saturday night. standing on the corner and minding his own business. So examples of your charts. So the CPT codes in the States look at sort of different levels. Now, again, if you look at the last column on this table, these are the values. So a level 1 chart is worth roughly $127. This would be your cellulitis recheck or your medication request, prescription refills. You might have 1 to 3 lines in your history. You might look at one organ system, or you might not. And there really is no decision to make. Do I refill the prescription or don't I? That's really it. You go to a level 3 chart. You know, this is sort of more moderately complex. So this might be your sprain or your fracture, you know, ankle fracture. Somebody comes in with a sore ankle. So again, 1 to 3 lines. You might review the MSK system, system. You might look at a couple of organ systems, and you have a little bit more medical decision making. And then obviously, if somebody comes in with an acute STEMI or sepsis, then that's going to be a much more complex chart with multi-systems involved. And these are just some examples of you know, types of presentations of the different levels. And again, you know, I think our charting should reflect the same, that your medication request doesn't really require a large history and physical, but you know, your septic or traumatic patient certainly does. And we have adjuncts in our trauma notes. It's an example of somebody that comes in with abdominal pain. And certainly, you know, I don't know, this was more of a, what I would call a medical student a chart. You know, all of our medical students, when they come in, although we keep trying to teach them to take focused histories and physicals, most of the charts end up looking like internal medicine notes. But you can see the pertinent positives and negatives are there, you know, aggravating and alleviating factors, past history, the social history, surgical history. They've done a complete review of systems, looking at the vital signs. They've looked at the physicals. I don't think the assessment and plan that's here is entirely necessary, given that most of our, you know, you could put your differential in biliary colic versus cholecystitis. You know, we'll place an IV and check CVC, LFTs. All of that stuff is noted in our order set. Toradol for pain, again, is noted in the order set. Interestingly, Norwick Bernies for tenderness shows that whoever wrote this chart wasn't entirely aware of their thought process, because I believe under the surgical history, the patient had an appendectomy in 1992. So that's probably a little unnecessary. And this is a bit wordy. Certainly takes a lot of time. You see that they've gone back and they've documented all their patient interactions. And you know, this is almost a nursing note level at this point, where they've gone back multiple times. I don't think too many of us go back at 3, 340, 402, 408, and 415 to see a patient unless they're critically ill. Certainly not for you know, cholecystitis. So funny things that you find on charts. She'd been constipated most of her life until 1989 when she got a divorce. You know, the second day the knee was better, and on the third day it completely disappeared. So these are just some funny things that if you go back and read your own chart, you'll look at things sometimes and go, wow, did I really say that? But yep. So when we look at the types of charts, so, you know, ours, as I said, are a combination of electronic medical record and handwritten. We do most of our work on the handwritten chart, but are able to put in allergies and medications, as well as orders in the electronic medical record. There is a place there for typing notes as well. If you look at handwritten charts, they're cheap. They're really, you just have to print them out. They're quick. They're even faster when you don't complete them, and only limited by thought, and in my case, artistic ability. You know, they can be a little bit slow. They can be, there can be risks of inadequate documentation. So if you've got we'll talk about some of the others, but things like a T-chart or an EMR, you got to fill in all the boxes, so you can't really miss or leave things out. And certainly there's you know, legibility is a problem. So sloppy appearing charts, continuity of care is difficult if you can't read what the other person had. So this is the sort of the title of my talk, and you can see here, I don't know if you can see my mouse, but there's someone that looks like they've written in Sanskrit, and all the way down to the EMR, which typically is a sans serif font. So your charts can go anywhere from one to the other, and I suspect if we look at this, we'll all recognize who and where we are, particularly at one point in our career or another. Dictation. Dictation has gotten a lot better. I did a lot of this talk using Dragon Dictation, which I have at home. There's a medical version, which does a very good job of not messing up the medical words. Our radiology colleagues are all using speech-to-text software now. So I think it's helpful if you've got to do a lot of typing. It doesn't work real well in an EMR where you're doing a lot of clicking. And certainly can be difficult, you know, because there's no way to diagram, and certainly difficult because if you're a word slur, or if you have heavy accents, or you speak clearly, or you're a mumbler. We've all, I won't mention names, but there's a certain radiologist that we've all tried to listen to his dictations, and it becomes a little bit difficult. I'm not sure how the program manages to pick that up. Templates. When I started in this department, we had templates that they would stamp. They were just a big giant ink pad stamp that they would stamp on charts for belly pain or chest pain, which worked really well until the person came in with high abdominal pain, which on further review was actually chest pain, and you've got a big stamp on your chart for abdominal pain that's filling the entire page, and you've got to try and work around that. So certainly there are issues with templates. You know, they can be helpful in some ways because you can incorporate your QI directives into them. So if you're, you know, if you've got a template for DKA, much like we have a protocol, if the protocol and the chart are basically the same thing, it kind of makes it difficult for people not to follow the protocol. It increases productivity and also allows you to not so much here in Canada, but in a fee-for-service environment, allows you to bring rapid attention towards your billing requirements. They're expensive. If you go online and look at T-Sheets, which is one of the commercially available, they've got 82 different templates, and of course that means you have to purchase 82 different templates. The more templates you have, the more the learning curve is, and the worse the problem. And as I mentioned, you can end up grabbing the wrong template. So this is an example of a simple template for a physical exam. And you can see that, you know, you can just, and this one has a little documentation area, but you can see you can just write a few words, but you get an awful lot of information just through your checks and ticks. And then someone on the left has documented that on a repeat exam, there's no change. Scribes. So if you go to ASEP, it seems like every, I don't know, 8th or 9th booth there is, you know, some company trying to either entice people to become a scribe or to sell you the services of their scribes. And it's a big business in the States because they use a fee-for-service model, and throughput matters. So the average salary for a scribe in California last year was $37,000 a year, which ranged from about $31,000 to $54,000 a year. You know, but a scribe, you know, if your scribe is well trained, and certainly in a physician office, you know, your scribe may help with your procedural setup. They can be your chaperone, or in Newfoundland, they can be your gopher, or a gofa in Newfoundland. And you can cross-train them to do other things like a blood draw or ECGs or just take vital signs. But sometimes you can't afford charts, and when you can't afford charts, you can do what some local people did here. They created a project to get volunteer scribes. So this was I think most of you were around last May when David was doing this in the department. Essentially, they got 5 undergraduate students and 5 medical students, and taught them to be scribes, and several of our physicians were involved as well. And they wondered if scribes would be, you know, undergraduates would be willing to scribe in exchange for clinical exposure and experience, and if scribing should be integrated in the medical school amongst other things. Medical students thought it provided a unique value because they got to see, sort of histories and physicals, and they got to see a different aspect of medicine other than just shadowing. And some mentioned they thought it might be able to be added to the year 1 of the curriculum. Certainly, I know when I was interested in medicine, to be able to come and be a scribe would have been a lot more fun than being a patient assistant on a geriatric floor. So there's lots of people that, for various reasons, are looking to do volunteer work in the hospital. And I'm sure that, feeling that you're making a difference and also being exposed to the process of an emerge visit would be helpful. So EMRs. So one of the difficulties with EMRs is, of course, they are there's a high learning curve. I mean, even just to get into our LScript system, it took a while, and it takes time. And probably the biggest issue is they're electronic, so they work until they don't work, and then you're stuck with paper charts and doing things differently. But I do think it would solve a lot of the issues we have in terms of trying to pull old charts, find missing old charts, the legibility of charts, to have more of that information in the computer system. And that's something I think that needs to be discussed. One of the studies that was done as they were implementing EMRs in the US in the last decade is Robert Gilla and his group looked at study participants in a community emerge. They tracked each participant for 30 hours. They recorded the time spent in a bunch of different categories. And they used a dictation software instead of free typing. And so this is an example of, sorry, this was meant to be up above. It's an example of, we talked about not being able to document an EMR, but this is actually the part of AllScripts that you can purchase for their Emerge EMR. So you can use this little man, click on him, and identify sort of injuries that he may have. So it does allow for some level of diagramming. Sorry, back to the study. So they looked at the mouse clicks for various tasks. So just to order an aspirin, it took six mouse clicks. To review a test in an old record, it was 11 mouse clicks. So they looked at if you saw between 2 and 2.5 patients per hour, that was anywhere from 3,200 to 4,000 mouse clicks a day. And interestingly, they found that there was no difference between free typing and dictation software as far as the legibility and the accuracy of the chart. Here in our Emerge, 3 to 5 minutes to log on initially. Subsequent logins tapping in 35 to 45 seconds. You've got a click to select the patient, a click to enter order, a click to bypass the allergy screen, a double click to assess the ED assessment order set, and then 1 click per order entry on that list. And that's just to put the orders in. What they found in that particular study was that 44% of our day is spent doing data entry. And only 28% of our day is spent doing patient contact.
Oh my Lord.
So, when you look, this is a note that's when they were implementing EMRs, a gentleman, emergency physician in the US wrote in the medical journal. I think the third last paragraph is probably it. The issue was that physicians weren't getting their EMR records from patients going into Emerge. And what happened was, although the doctor was assigned to the patient on 4 different steps, it only worked if the doctor clicked on the attending physician or the patient's family physician when he wrote the discharge instructions. And so the comment that this particular physician made is that medicine is often compared unfavorably to the airline industry and its failure to use checklists to avoid mistakes. Well, I'm pretty sure there's no checklist that requires a pilot during takeoff to go into the cabin and ask who ordered the fruit plate. And that is the element of some of these things. And I think as these EMRs get better, they become more user-friendly. But certainly on the top line on this slide, as we get into training programs, there's no doubt that I'm an old fogey now as far as electronics go. Certainly, I think a lot of our newer grads and newer trainees have been using EMRs entirely through their entire medical career. I still remember running down to the radiology room and asking to sign out the films. So, you know, we've come a long way, and I think there's room for improvement. But your environmental design, I think, is important. And, you know, where are the computers? Are they central in the department versus peripherally? Are they in the rooms? Unfortunately, now we have to ask the question, are they socially distanced? Is there a particular place? If you go to a dictation type system, do we have a place to do that? And then last, are we minimizing our interruptions? And I suspect not. Again, another study of looking at implementations of EMRs, and this particular study in 2017 suggested that the length of stay increased by 8.4 minutes per discharged patient. It didn't affect the length of stay of admitted patients. I think, you know, as these EMRs get better, we'll find that the information that we put in is worth the time it takes. And then medical students, what do you do with your medical students? Do you let them write on the chart or not? And I think, you know, that we expect them to be able to chart properly. We expect them to communicate with their colleagues. So I think you have to expect that they're going to have to write on the chart. I like to ask my students to leave me a space so that I can write my comments on the chart, but that's helpful. They did a study looking at a group of folks in the States, and most of the schools responded, felt that their fourth-year students should be writing on the paper charts. Teaching hospitals were much more restrictive at letting people into the electronic medical record, and I think we've made some restrictions over the past few years in terms of allowing students to order things. This chart by Lorenzi in 2018 looked at strategies for improving physician charting. I'm going to just go through it quickly. So they looked at audit, feedback, dictation, education, where someone came in and explained to people why it was important to do charting. Facilitations was that the pharmacist would come down and look at all their medications and remind physicians about the medications that they were required to have. They looked at whether or not using structured paper templates helped people, and then there were sort of multi-interventions. And interestingly enough, the audit feedback system was the one that improved the completeness of the chart the most. Voice recognition software decreased completion time, but then of course the accuracy also decreased because for all the reasons we talked about earlier, if once your voice is trained in Dragon, it tends to do a much better job, but initially it may make a lot of errors. You know, having someone come in and talk to people about the value of charting and the dangers of not charting properly didn't really improve charting at all. When you looked at up here, the structured paper templates, it improved reminders, improved specific item quality that were on the reminders, but didn't really do much overall. And sort of templates improved in 3 studies, and in the other 4 studies received mixed results. It did not reduce the wait times. So the last part of the talk is just to let everyone know, it used to be the Atlantic College's peer review council, which has now gone defunct, and the job is being taken over by the College of Physicians and Surgeons. If you go onto their website under the peer review section, it tells you that there's an intent for them to review a physician at a mean of 5 years and a max of every 10 years. Once they reviewed your charts, they're going to have some factors that they will have established beforehand, which will determine the frequency of assessment for an individual physician. And obviously, if you're higher risk, you'll have more chart. I've just switched screens. Hopefully you can see this. So this is a sample of their peer assessment report. And I'll scroll down through it. The link is here if you want to click on it yourself, or you can go to the college site. A lot of this, they go through and look at everything, including the physical facilities and equipment. And although that's not your responsibility, if you find that there's an issue with your facility or with your equipment, this is an opportunity to have them advocate on your behalf to get it improved. Contents, so they look at it as always, usually, sometimes, and never. And these are the sorts of things that they're looking for. Now, everything on this part is essentially driven by triage and nursing, except for maybe the dates of immunization. And then the last one is, again, in the event that more than one physician is making entries in the file, is each physician identifiable? Well, I think the difficulty, as I've mentioned already, is sometimes we can't even identify the physician of record because the signature is not legible. So the process of this is they'll draw somewhere between 15 to 25 charts somewhere in the last 3 months, and they'll look. The charts, the reason I talked about resident charts is that the chart may have been written by a resident, but it still counts as your chart because you've signed off on it. Any chart that you got in handover, I was lucky because several of the ones they drew on me were Lorena's charts, and she is an excellent charter. So Dr. Turcott, I think, made me look really good. I appreciated that. Looking at sort of the SOAP notes, so again, functional inquiry. I mean, these are things that we've already talked about that are there, but they are going to look for them on a point-by-point basis on a history of somewhere between 15 and 25 charts in the last 3 months. So it is important to kind of look at your chart. Overall comments on the records, again, they'll make some comment on patient care, whether or not things are well documented, whether or not there's a management plan, whether or not the drugs prescribed were appropriate. Again, because our charts are sort of a combination of paper and electronic, some of these things like the indications for surgical procedures are documented. So, and management plan, including, and then management plan, including consults are documented, investigations are documented. That's all in the computer system. The records that indicate the physician is aware and utilizes various supportive social agencies from his or her community. I don't know that is entirely something that we do a lot of, but it's there. You will be reviewed by someone on the committee who is an emergency physician. Typically, they use someone in the province now because it is the New Brunswick College. In the old Atlantic Council organization, the person who reviewed me was someone that was from Nova Scotia. So that's essentially it. Looking back, think about the answers to your earlier questions. What can we do to simplify our charting here? Can we make changes to improve things in terms of ergonomics or environment? Is now the time to implement an electronic charting? I mean, with COVID, our volumes are down a bit because of our nursing shortage. Our flow is down a bit. So, if you need a time for a learning curve to implement sort of new charting, is now the time, given that the flow tends to be a little bit low. Do we need a charting room? Should there be a place where we can go to discuss patients that's not sitting in front of the patient in room 11? Anyway, thank you very much, and I'll take questions if you have any.